Hello and welcome everyone. Today we will discuss the DSA guidelines on Pseudomonas aeruginosa with difficult to treat resistance, the DTR Pseudomonas aeruginosa. In 2017, 32,600 cases of MDR Pseudomonas aeruginosa were noted in US hospital, resulting in 2,700 deaths. MDR is defined as a Pseudomonas resistant to at least one antibiotic in 3 or more classes. Now, DTR is resistant to a wide range of antibiotics that are commonly used to treat Pseudomonas like piperacillin, tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem, ciprofloxacin, and levofloxacin. MDR and DTR Pseudomonas developed through various mechanisms, that is, reduced outer membrane porins, altered Pseudomonas derived cephalosporinase enzymes, upregulated efflux pumps, mutation in the penicillin binding proteins, and certain beta lactamases. Carbapenem resistance is caused by carbapenemase production, which is primarily due to WIM enzyme, and testing against novel beta lactam agents is strongly encouraged. So let's look at the questions. So what is the preferred antibiotic to treat infection caused by MDR Pseudomonas aeruginosa? Now, preference for traditional non-carbapenem beta-lactams. When Pseudomonas is susceptible to both traditional non-carbapenems and carbapenems, non-carbapenems are preferred to preserve the carbapenems for future. High-dose extended infusions is recommended to treat these infections. Use of novel beta-lactam agents in critically ill patients or with poor self control with isolate resistant to carbapenems can be tried. In these patients, continuously monitor the clinical progress and repeat antimicrobial susceptibility testing to look whether resistance is developing in these isolates. Now, what is the preferred antibiotic to treat uncomplicated cystitis? Now here, we'll look at the alternative agents first. Single dose aminoglycoside, that is tobramycin or amikacin, can be effective since it is primarily eliminated by the kidneys and is beneficial in cystitis. Colistin is an alternative and can be used if the risk of nephrotoxicity is noted. Avoidance of oral fosfomycin should be done because it is ineffective against Pseudomonas aeruginosa. Now, if we look at our main agents, the main agents would be cefotlazone tazobactam, ceftazidime avibactam, which has been shown to be non-inferior, imipenem cilastatin relibactam, and cefiderocol. Now, if the infection is a complicated cystitis or pyelonephritis, in that case, what are we supposed to do? Here you will go for ceftolazone tazobactam, ceftazidime avibactam, imipenem cilastatin relibactam, or cefiderocol. So these are the 4 agents which can be preferred. Now, they have been shown to be effective in non-inferiority trials, and there is currently not enough data to show which of these agents is to be preferred. Now, in situations where the risk of nephrotoxicity is acceptable, tobramycin and amikacin can be used as an alternative, although caution should be exercised due to potential of kidney damage. Now, this treatment option aims to effectively treat pyelonephritis and complicated UTI caused by DTR using antibiotics with demonstrated efficacy in similar infection and consider severity and complexity of these conditions. Now, next we go into outside urinary tract if there is an infection by DTR Pseudomonas. Then the drug is ceftolazone tazobactam because of in vitro activity and observational trials, ceftazidime avibactam because there have been some observational studies, and imipenem cilastatin relibactam as it has shown in vitro activity. Finally, cefiderocol. It is an alternative. So next what we look for is the preferred antibiotic to treat DTR aeruginosa which produce metallo-beta lactamases. Now if that is the case, there is very limited prevalence of these type of organisms in the US, though they are more prevalent in other parts. The susceptibility to cefiderocol, the metallobeta-lactam it is produced, remains susceptible to cefiderocol, making it as a viable treatment option. Limited clinical data suggests a higher rate of clinical cure with cefiderocol compared to alternatives for metallobeta-lactam. Now, a combination therapy of ceftazidime avibactam with aztreonam is less likely to be beneficial, producing Pseudomonas because of multiple resistance mechanisms that are already present. Next, what we look for is the likelihood of emergence of difficult to treat Pseudomonas in the newer beta-lactam agents. Now, in that case, ceftolozane tazobactam and ceftazidime avibactam, the available data suggests that the frequency of resistance may be the highest for these two agents. The resistance often involves Pseudomonas-derived cephalosporinase, that is called the PDC enzyme. Now, the mechanism of resistance is typically due to the mutation in the PDC, probably in the omega loop region. Now, in the ceftazidime avibactam, similar type of changes result in resistance. Now, resistance to imipenem cilastatin relibactam is due to the increased PDC production, loss of OPRD, and overexpression of the efflux pumps. Now, resistant to cefiderocol includes the mutation to TON-B dependent iron transport or change in the AMP-C beta-lactams. Now, cross resistance, there is a high level of cross resistance present between ceftolozane tazobactam and ceftazidime avibactam due to structural similarities. Studies have shown that a significant percentage of patients treated with ceftolozane tazobactam develop subsequent isolate resistance to both of the agents. Now, frequency of resistance in these imipenem and cefiderocol is limited data. Now, always repeat antibiotic susceptibility when treating patients with difficult to treat resistance of Pseudomonas, because there is always a risk of new or relapse infections. If a patient is recently been treated with ceftolozane tazobactam or ceftazidime avibactam and there is a symptoms of recurrent infection, then consider using imipenem cilastatin relibactam or cefiderocol. Next, what we look for is the role of nebulized antibiotics in this particular scenario. Now, there have been conflicting clinical trials. Observational studies have shown conflicting results with the nebulized antibiotics. Several clinical trials investigating nebulized antibiotics in VAP did not demonstrate improved clinical outcomes or survival, even with drug-resistant pathogens. A meta-analysis indicated some resolution of clinical symptoms, but no survival benefit, or reduction in ICU stay or reduction in ventilator days. Nebulized antibiotic may not achieve sufficient penetration in the distribution in the tissue, particularly due to suboptimal delivery and the use of parenteral formulation not designed for inhalation. There are concerns about the inability of the nebulized antibiotics to uniformly distribute throughout the lung tissue. Now, use of aerosolized antibiotic can lead to respiratory complications like bronchoconstrictions. Despite the panel's recommendation against nebulized antibiotic, professional societies have expressed varied opinion on this particular method, and it can be used as an adjunctive agent to intravenous antibiotics. Thank you for your patience and hope you liked our presentation. Then give us a like and share this video.